Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is psychiatric medications and epilepsy, and we're pleased to have as our speaker Dr. Jules Constantinou, who's a pediatric epileptologist with the Henry Ford Comprehensive Epilepsy Center. Dr. Gregory Barkley will unfortunately not be able to join us today as originally planned. Dr. Constantinou, can you briefly introduce yourself, talk a little bit about your clinical and research interests, and describe your experience with this topic?
Well, thank you so much, Russ, and thank you for the kind invitation. And I extend Dr. Barkley's apologies. Greg and I work very closely together, but as Russ says, he had a scheduling conflict, so I apologize for that, but I'm hoping I'll be able to. It's always hard to step into Greg's shoes, but I'll do my best. And so yes, I'm a pediatric neurologist and a pediatric epilepsy specialist. So I work at the Henry Ford Comprehensive Epilepsy Program, and my clinical interests. I have broad-ranging interests in epilepsy and seizure disorder, and I think also, particularly in terms of we really shouldn't call them comorbidities, but for lack of a better word, I think, as we know, epilepsy is often associated with mood disorders, with anxiety. In childhood, we deal with learning disorders and ADD and autistic spectrum disorder. So those are all conditions which can accompany epilepsy. So I think I think part of what we try to do at Henry Ford is to provide comprehensive care, and what that entails is addressing not just the seizures, because as you all know, epilepsy many times is more than just the seizures. And I think today what we're going to focus on is the mood disorders and the psychiatric disorders which can accompany epilepsy.
Right, great, thank you. As you mentioned, people with epilepsy are at increase for depression, anxiety disorders, and other psychiatric disorders as compared to the general population. Can you talk a bit about the epidemiology of mental health conditions in people with epilepsy? Right.
So, as we said, mental health issues are common in people with epilepsy. And it's actually not a new observation. As I was reading about the topic, Hippocrates, 27 centuries ago, sort of said that, people with melancholia, which is Greek for depression, I guess, often develop epilepsy. And the other way around was that people with epilepsy will often develop melancholia. And so this is an old observation that, depression, anxiety, and epilepsy are often intertwined, and, we'll talk about this a little more, but, depression and anxiety are often under-recognized and they are undertreated. And, what are the reasons for that? I think part of it may be that, sometimes when you're with your neurologist, there's only, you get 20 minutes or, Henry Ford, we will give you 30 minutes for a follow-up. Greg allows me to spend 45 minutes with my follow-ups so we can address all the issues. But a lot of times there's a time constraint, and it's, sometimes it's hard to get beyond the seizures and just the medication. So maybe that's part of the reason. Another reason that depression and anxiety may be under-recognized and undertreated, it may be the perception that, well, that's what else do you expect? There's a model of depression, and what that model is they get mice or rats or rodents, and it can be a mouse, it can be a rat, and what they do is they plunge these mice and these rats into buckets of cold water, and then they're expected to swim, and then they take them out again, and then they put them back in again. And, of course, that the sudden, unexpected thing that happens to you is going to generate anxiety and is going to generate depression. So they use these mice, these swimming mice, as they use them as testing models for new antidepressant agents. What they do is when an antidepressant or an anti-anxiety medication is being developed, they'll use these mice and they'll try these. Maybe in some perspectives, ideas, it might be that, well, what do you expect? You have unexpected attacks, you lose consciousness, and this is just what we would expect. But I think it's more to it than just that, and I think that we are beginning to understand the neurobiology and the neurobiological links between anxiety and depression. And, people talk about a bi-directional relationship between anxiety and mood disorder and epilepsy. So if you look at people with epilepsy, mood disorders and anxiety are more common before the epilepsy is diagnosed. And also, if you develop epilepsy, then you're more likely to develop anxiety or depression afterwards. So there's this interplay between mood disorders and anxiety and epilepsy. So estimates of the rates of, every article you read has a slightly different estimate of what is the exact prevalence, what is the exact incidence. And, we have to distinguish incidence from prevalence. So incidence is, every year, how many people in a particular group will develop anxiety or depression, whereas prevalence is over time, what are the chances that you will develop a particular disorder. So if we look at depression, and, depression can be mild, where it doesn't impact particularly on your daily living, on your occupation, on your interactions. It can be moderate, which is where it does have some impact on work, or it can be severe, where it can be major depression, which is disabling. And, estimates of, they would suggest that maybe up to 20% of people with epilepsy at some point or other may develop a major depression. So anxiety has a similar prevalence to depression, and a lot of what we sort out, anxiety and depression, it's perhaps less frequently recognized or less frequently treated. And I think, the failure to recognize anxiety, the failure to recognize depression is not limited to people with epilepsy. I think as a general rule, there's a study in Germany where they looked at people with depression, and it looks like people with depression are recognized and treated only about 30% of the time. So 2 in 3 people with depression do not get treated for it, and those who do get treated, maybe only about a third continue treatment. And again, there's no epilepsy-specific rates, but it is shocking, isn't it? I mean, we only recognize it a third of the time, and when we do recommend treatment, that you need treatment, only a certain proportion of people will continue the treatment, and maybe that's because of lack of follow-up, side effects, tolerability, issues like that. So anxiety is similar to depression, but it's less frequently recognized or treated. A population study in England showed that if you have epilepsy, anxiety is 2.6 times more common in the general population. So if you have epilepsy, 2 to 3 times more likely to develop anxiety than someone who doesn't. And it's not just adults. I think, of course, children who worry about, epilepsy and seizures. If you look at children with new onset epilepsy, up to 35.8% will report symptoms of anxiety. So anxiety, depression, and so what I submit is that these are not comorbid disorders. So I think that's a horrible term. We should think these as part of the epilepsy process. Anxiety and depression often they're part of the pathophysiology of epilepsy, and it's important to recognize. And why is it important to recognize? Because the psychiatric issues, the comorbidities, it's hard to get away from the word. Those issues, the anxiety, the depression, are a greater predictor of quality of life rather than seizure control or severity. If you do quality of life studies in people with epilepsy, it's not so much seizure frequency, it's not so much seizure intensity, but it's mood factors and anxiety factors which impact quality of life.
Right. That's so important to recognize. Thanks for bringing that up. In terms of prevalence, have there been any studies to demonstrate that certain types of epilepsy are at higher risk for depression and anxiety, or is it fairly similar across the board?
Yeah, so that's a good question, Russ. I think much of our knowledge and our understanding stems from temporal lobe epilepsies, because frontotemporal circuits, the temporal lobe and the frontal lobe, are important in terms of generation of symptoms of anxiety and depression. So the idea is that it's more a phenomenon of temporal lobe epilepsy, but none of the studies that I accessed actually distinguish between generalized and focal epilepsies. But I think the idea or the impression was that really both groups of epilepsy, whether it's generalized or focal, there's a high correlation with anxiety and depression. And again, knowledge in childhood is limited. We don't really explore issues of anxiety, or it's not methodically studied. And many times the pediatric neurologists will focus on issues of ADD and attentional difficulties and learning issues, but we do know that ADD and anxiety often run together.
Right. So as you referenced, the challenges of living with a complex chronic health condition, particularly one as unpredictable as epilepsy, can all contribute to the development of mood and anxiety disorders. But there's also a variety of factors related to genetics, some brain structure and brain chemistry that can help to explain the association between epilepsy and mental health disorders. So without going into too much detail, can you briefly discuss what we currently know about the possible structural and biochemical mechanisms behind this association?
Again, that's, as we said, there's a bi-directional relationship between mood and anxiety disorders and epilepsy. So if you look at epidemiologic studies, the risk of anxiety increases before the onset of the epilepsy. So even before you develop epilepsy, there's increased anxiety. And then also in the years of follow-up after the onset of the epilepsy. So intrinsically, there's got to be something going on neurobiologically. People that have mood and anxiety disorder have a 2 to 7 times greater risk of the later development of epilepsy. There's a bidirectional relationship between suicidality and epilepsy. So if you look at before the diagnosis of epilepsy, there's a 3-fold increase in the rate of suicide. After the diagnosis, it's a 2-fold increase in the risk of suicide. So there's a complex bidirectional relationship between mood and anxiety disorder. The UK General Practitioner Database did a very nice study where they compared rates of anxiety in people with epilepsy, people with asthma, and diabetes. And what they found was that if you have epilepsy, you're more likely to have anxiety than someone with another chronic disorder like asthma or diabetes. So it's a neurological basis. But the incidence rate of anxiety in the UK practitioner database was the anxiety is 2-fold, twice as likely in the 3 years before and the 3 years after the diagnosis of epilepsy. So when we look at that, so there's this complex neurobiological relationship between anxiety and depression. Symptoms of anxiety and depression often develop before you even having your first seizure. The other thing also is that anxiety and depression can increase the risk of a less favorable outcome in terms of seizure control. So patients that have anxiety are less likely to obtain seizures control. So there was this acute major depression, anxiety. There was a Scottish study which showed that if you had premorbid anxiety, so if you had anxiety before your first seizure, that increased the risk of drug-resistant epilepsy that you couldn't control with medication more than 2-fold. People that have anxiety, major depression, also have a worse prognosis after epilepsy surgery. So there were 3 studies which, if there's a psychiatric comorbidity, and the one study from Brazil, you're twice as likely to have a less than favorable outcome from epilepsy surgery. So again, that speaks to the common neurobiological thread between seizures and mood disorders. They did a study, this was from Connecticut, which was a longitudinal study of childhood onset epilepsy. So they looked at children who presented with epilepsy, and then they looked at a family history of unprovoked seizure. And what they saw was that if you had this family history of unprovoked seizures, those members were more likely to have increased anxiety at 9-year follow-up. So there seems to be in pedigrees, in big families, there's this relationship not just with seizures but with anxiety. So what underpins do we think the relationship between seizure control, the bi-directional relationship? And there's two main theories. One is the neuroanatomical theory, which is that in the brain, the seizures often involve the limbic structures. These are the deep structures in the brain responsible for emotion and fear. And then the other group of theories is the neurotransmitter theory. And that neurotransmitter theory is, we're all products of our neurochemicals. So, there may be variations of our neurotransmitters, the serotonin, the norepinephrine, and the GABA, which are key. The amygdala is deep in the brain. It's in front of the temporal lobe. And the amygdala is key in regulation of emotion and memory and how we process the emotional context of fear and of memory. So the amygdala has rich connections. It's in the old part of the brain. So it has deep connections within the brain with the thalamus, those connections can. I'm just looking for. So the amygdala is instrumental in generating anxiety, and that's where seizures often come from. If you look at the outputs of the amygdala, so the amygdala is connected with the hypothalamus. And so that amygdala-hypothalamus connection, so seizures often involve the amygdala, but that goes to your blood pressure centers, so you get your blood pressure goes up, you get jittery, you get tachycardia, you get a high pulse rate. The amygdala is connected to the brainstem, to the raphe nuclei. So if there's an anxiety charge, that might mediate what we call avoidance behavior. So you're going to hide, you're going to shrink, you're going to, if you're a teenager and you're depressed, you're going to sit in your room and just watch television and not interact with your family. So I think that's, that neurobiological theory that links the mechanisms of epilepsy and mood disorder, which most theories focus on the amygdala. If you do MRI studies in people that have ictal fear, so sometimes fear can be a symptom of a seizure, you have decreased amygdala volume. The amygdala is of less volume. If you compare healthy adults with people with anxiety, no seizures, then they also have low amygdala volume. You can also do PET scans. So PET scans are positron emission topography studies where they inject a low dose of a radioactive substance. And so they did studies in people with a severe mesial temporal lobe epilepsy and a similar study in people with panic disorder. And they found very similar changes in metabolism of neurotransmitters in both temporal lobe epilepsy and with panic disorder. So we saw reduced serotonin binding, and serotonin is one of the chemicals which is important in generating anxiety, fear, depression. So we had reduced serotonin in the anterior cingulate, the posterior cingulate. These are the cingulate is above the corpus callosum. It's sort of part of the limbic system, part of the emotional circuit. But you have the serotonin abnormalities. So lots of threads. Right. We have the amygdala, the anatomy, we have the neurotransmitters, and a genetic component in that there seems to be a genetic component that underpins both anxiety and epilepsy.
Right. So yeah, it definitely sounds like there's a clear association both neurobiologically and genetically, but we have some understanding of the possible mechanisms or nature of that, but a lot to learn, it sounds like. So this is a major oversimplification, but psychotherapy can generally help to address the life circumstances, behaviors, and thought processes that contribute to anxiety and depression, while psychiatric medications can address the biochemical factors. So because most cases of depression and anxiety involve a variety of factors, a combination of psychotherapy and medication can often be the most effective treatment approach. Can you elaborate on this and share a bit about what the research has shown regarding the effectiveness of various treatment strategies for common mental health conditions?
Okay. So, so I think, as we said, anxiety and depression, they're not comorbid. They're part of the epilepsy. And so as a neurologist, what your neurologist should be screening for anxiety and depression as part of good quality care, and so there's simple screening tests that, do you feel down? Do you feel depressed? Are you hopeless? Sometimes there's these rating scales that we can use. But before we start, as part of the process of trying to explore the issues of anxiety and of depression, we want to consider, could it be, because anxiety and depression can relate to seizures. So it's something that we call periactual anxiety. So what does periactual anxiety mean? It means anxiety either before the seizure or during the seizure or after the seizure, you see? So I don't know, I think if maybe when we adjourn and when we start asking questions and when we have our group discussion, I'd love to hear from people. Can you predict your seizures? Can you tell? This is what we call the prodrome. And I'll see that sometimes in children. Families will say to me, sometimes it's behavior, sometimes it's mood, sometimes it's withdrawn, but it's like we can predict the seizure. It's the calm before the storm, So they did a seizure prediction study, and if you self-reported anxiety, you were more at higher risk of a seizure the following day. So there's periactual anxiety. And there's also ictal anxiety. So anxiety can be caused by a seizure. I think you need a professional input, and I don't want people to be thinking that all anxiety is seizures, but very occasionally, as a temporal lobe seizure, anxiety can be one of the symptoms. And we can tell the difference. Ictal anxiety is anxiety because, remember, the amygdala, which is right in the middle of all of this. So ictal anxiety, there's a sudden onset, intense fear. It may be similar to a panic attack. But a panic attack is longer. A seizure generally is 1 to 2 minutes. So any of you that might want to share what it's like having a panic attack, I'd love to hear about that. But panic attacks are longer, they're 5 to 10 minutes. They come only from wakefulness, whereas ictal fear, it's shorter and it can wake you up from sound sleep. And then there's also mood disorders after a seizure. And again, 50% of people will say that after they've had a seizure, there's increased symptoms of anxiety, you see? So it's always important to try and dissect out the issues of anxiety related to the seizure. And if it's a pure periactual around the time of the seizure phenomenon, then what you can do is aim for better seizure control. The anti-anxiety medications are not going to work. So that's number one. Is it a seizure phenomenon or around the time of seizure phenomenon? The next step is to say, is it anxiety related to issues related to the epilepsy? So, when we look at anxiety scales, we sometimes have to, sort out, is it a neurobiological anxiety, or is it anxiety because we haven't really explained your epilepsy? Is it the fear of seizures? Is it uncertainty about the diagnosis, about uncertainty of the treatment path? So, making sure that there aren't knowledge gaps in terms of the epilepsy and whether or not that could be contributing to the anxiety. We want to make sure that the anxiety or the mood disorder is not a side effect of your medication. So, we know that some medications in a small subset may be associated with mood disorder. So, phenobarbital, primidone, Keppra, Zonogram, levetiracetam, zonisamide or Zonogram, topiramate or Topamax often can be associated with anxiety, you see? So it's not a side effect of your medication. It's not the phenobarb or the primidone or the levetiracetam that I'm giving you that is making you depressed. It's not withdrawing. There are some medications which have anxiolytic properties. So, mostly these are things like gabapentin, pregabalin. So gabapentin is Neurontin. Pregabalin is Lyrica. Valproate is Depakote. Benzodiazepines, that's Valium and your Xanax, your barbiturates, and sometimes withdrawing medications, if stopping a medication may increase the anxiety. So is the anxiety exclusively related to the epilepsy? Is it related to gaps in understanding of the epilepsy? Is it related in some way to the seizure meds that we are prescribing? Either giving you a medication that that brings on the symptoms, or taking away something which might have helped. And then having looked at that, we mustn't, it's important to recognize anxiety, and I think that's going to be maybe the next question, I think, Ross, about why we should recognize it. But I think in the last 5-10 years, Russ, maybe, I don't know whether you'd say something different, but I think the shift has gone away from, pulling out your prescription pad, or, take some Zoloft, take some Paxil, take some Prozac, that's going to help you. And we are beginning to emphasize a psychotherapeutic intervention. And there's a lot in the literature about cognitive behavioral therapy, which is hard to find, but I think anyway some sort of counseling support is often helpful. So particularly in childhood, there's a recent what we call meta-analysis where they looked at, they pooled bunches of studies on anti-anxiety agents, on antidepressant agents, in mild depression, moderate depression, severe depression. And what they found, at least in childhood, and I think in adults as well, is sometimes the benefits from the antidepressant medications when depression is mild to moderate are small or none. So I think we're shifting paradigm, we're shifting thought processes, and our trend these days is to recommend counseling before we think about medication intervention. Though, if it's a very severe depression, if there's suicidal thoughts, if there's psychotic features, hallucinations, then that's a different situation.
Okay, so that's interesting to learn about that shift and particularly that study that how ineffective in general psychotropic medications are in mild to moderate depression and anxiety. So, having said that, that is the focus of this call. So we will continue to talk about kind of the role of medication.
Not to say that they don't have a role, and I think many times, I didn't want to knock medications completely because they can be very helpful, and many times we want a combined approach, not just with therapy, but also with medication.
Right. And I think the point that you made was typically starting first with psychotherapy, and if that is not sufficient, then potentially considering medication. So with all of this in mind, why is it so important for people with epilepsy who are struggling with anxiety or depression to seek treatment and not just try to deal with it on their own? I think sometimes people have this, lingering belief that mental health challenges are a character flaw or something you just have to tough it out and deal with it. Particularly, older generations may have that sentiment, and so just if you can talk a little bit about why it is so important to seek help.
So I agree, Russ. I think men in particular, we're not very good at talking about how we feel or sharing feelings of sadness or worry. If you're ethnic like me, it's not something that you really talk about, But I think there's barriers, but I think there are good reasons to try to overcome that, because we know that symptoms of anxiety and depression can impact on seizure control and on treatment. So, if you have anxiety and it's not, you're more likely to develop adverse side effects on medication. They did a study where they administered a hospital anxiety and depression scale, and then they asked people about side effects. So if you endorsed symptoms of anxiety, you were more likely to have unsatisfactory experiences with medication. There's increased economic costs, you see. They did a study at the Penn Epilepsy Center, and if you have anxiety, it's harder to take care of yourself. If you have depression, it's harder to take care of yourself. You've got to get that motivation. You got to get up to go. The people with anxiety and depression are more likely to miss clinic visits. They're more likely to be admitted to hospital because of a seizure emergency. There's an increased risk of death from suicide and poor seizure outcome. So with anxiety, there's a 3.6 times increase of lifetime suicidal thoughts. That was in an Australian study. In Brazil, there was almost 7 times increase in suicidal attempts. And also there's an increased rate of accidental death. It's not just suicide, but I don't know, tripping, and I guess the explanation might be that you're not as vigilant. So yeah, it impacts on your epilepsy care. It impacts on mortality, on suicide. So yeah, I think that's important. We talked about people with anxiety are less likely to achieve seizure control, are less likely to become seizure-free after epilepsy surgery. But is that part of the neurobiological issues, or is it, that's probably what it is.
Okay. So can you give a brief overview of the major classes of psychiatric or psychotropic medications, some of the conditions that they're used to treat, and then maybe some basic pros and cons of each class of medication?
Okay. So, there's a broad variety of medications, and there's new ones always coming out. And, as a neurologist, I sort of know my limitations. And I think what's reasonable for a neurologist, I think a neurologist should be able to initiate care with someone with anxiety and depression. And I think we should have some familiarity. But I think if significant symptoms continue despite a trial of more than 2 medications, then it's probably best to seek expert care from a psychiatrist, you see.
Right.
So in terms of what groups of medications they are, and this question, I'm sort of like thinking I'm back in medical school and just studying for the board exams, and what does this one do and what group is it in? Because a lot of times, it's. So I felt
sure, and you can just talk about some of the major ones like SSRIs or that type of thing. So.
Yeah. So we have the main groups are the old antidepressant medications, or what we call tricyclics. And these are, you'll recognize the names, things like amitriptyline or Elavil or clomipramine or anafranil and nortriptyline. And the older agents, the tricyclics, and all these medications work on the biogenic amines, on the neurotransmitters that we were talking about. Now these older medications have a broader range of side effects. They're often less well tolerated. So these days, when we do recommend anti-anxiety or antidepressant medications, we have 2 main groups. We have the SSRIs, and these are the selective serotonin uptake inhibitors. And these are names you'll recognize, like Zoloft or sertraline, Prozac, or fluoxetine, paroxetine or Paxil, citalopram or Lexapro, or citalopram is Celexa, citalopram is Lexapro. So these are the SSRIs. And these are more selective, and they're less likely to cause significant side effects. What people recommend, if you look, there's really no guidelines for how do you treat anxiety or depression in someone with epilepsy. The studies that we've talked about are all generic anxiety, generic depression. There's only a few studies which specifically address how, if you have epilepsy and anxiety, what's the best medication for you. But the recommendation generally tends to be either for one of these new generation, either a selective serotonin uptake blocker, and if you don't respond to one of those, then the other option might be there's the serotonin SNRIs, which is serotonin noradrenaline, and noradrenaline is another chemical, a neurotransmitter, and those are Effexor or venlafaxine, and then duloxetine or Cymbalta. So Cymbalta and Effexor. And they say if you don't respond to an SSRI, try an SNRI. They say if you have more of a retarded, what they call a retarded type of depression, where there's motivation, loss of energy, you don't really feel like doing a lot of stuff, try the SNRIs first. And then there are things like, Buspar, which is works on noradrenaline and dopamine, just other chemicals, and those are the groups that I'm most familiar with. There are studies. Sometimes we can use anti-epilepsy medications to help with anxiety, so there are some open-label studies which support you say in someone with epilepsy that has mild anxiety, you could try either gabapentin, which is Neurontin, or pregabalin. You'd have to be a bit careful with those. It depends on the type of epilepsy. If it's an absence epilepsy or a myoclonic epilepsy, you might see an exacerbation of seizures. So those are the groups of medication.
Sure.
Russ?
Sure. So in general, you talked about neurologists and primary care physicians, being able to initiate treatment, and then psychiatrists kind of being brought in if initial treatment attempts have failed. Is that pretty much true across the board for children and adults? I obviously I speak better to the situation in children. I find that pediatricians on the whole are reluctant to initiate treatment with an anti-anxiety medication or antidepressant medication, or even with a stimulant, if there's an ADD. So usually the decision to initiate treatment is made by a specialist. I think it depends on your primary care physician, if for an adult, how comfortable they are with the idea of prescribing either one of these SSRIs or the SNRI. I think many do. Okay. So we touched on a few of these, but a wide range of factors really go into the choice of which psychotropic medication to use in a person with epilepsy. So I just wanted to talk about a few of those. One being interactions with anti-seizure medications. Can you just talk a little bit about maybe those two main drug classes you mentioned and the potential for interactions with anti-seizure medications, and do those tend to be pretty manageable and simple to deal with from a physician's perspective, or can any of those be a little more complicated and risky?
So good question. So, all these antidepressant medications, and whether we think about the old tricyclics or we think about the newer generation SSRIs, SNRIs, are metabolized in the liver. So the liver is central station where all these drugs are, all these medications are metabolized. Now, the new antidepressants they have a more selective, the SSRIs, the SSNRIs, they have a more selective mechanism of action, and there's a low risk of what we call a pharmacodynamic interaction. If we compare that with tricyclic antidepressants, with monoamine oxidase inhibitors, and monoamine oxidase inhibitors are I'm scared of them. I won't prescribe them. They're an old class of antidepressant medication, and I think you really need a psychiatric specialist to prescribe them. So we're less likely to see what we call pharmacodynamic interaction. So what does a pharmacodynamic interaction mean? It comes from a Greek word, dynami, which is strength. Okay, that's where dynamite comes from, right? Dynamite, big, powerful, big explosion. So a pharmacodynamic interaction is where one medication interacts with another medication and you get symptoms. You get clinically significant symptoms. That's pharmacodynamic interactions. Now, those are less likely with something like an SSRI or an SNRI, you see? But whenever there's a mix of seizure medications and antidepressant medications, with some medications, there is a risk of interaction. So, there's an enzyme system in the liver, which is called the cytochrome P450 system. So that's a system which strikes fear in the heart of every medical student, because they have to remember whether it's a 2DC or a 3A4 interaction. So anti-epilepsy drugs, psychiatric antidepressant medications are metabolized in the liver through the cytochrome P450 system, you see? Now, some of the old anti-epilepsy drugs, it's a bit like the old antidepressant drugs, they are enzyme inducers, you see? So these are things like the dilantin or phenytoin, phenobarbital, primidone, carbamazepine or tegretol, rufinamide or Banzel, so they will induce your liver enzymes. So they increase the activity of the cytochrome P450 system. That's where your antidepressant medications are metabolized. So it juice up your liver. These medications juice up your liver is a colloquial way of putting it. So if you are on one of these anti-epilepsy enzyme inducers, and typically the main ones are dilantin, phenobarbital, tegretol, those are the ones that are common, you're going to increase your rate of clearance. You're going to increase the rate of elimination of your antidepressant medications. So if you're prescribing Zoloft or Paxil or Lexapro, you may have to increase the dose of the anti-anxiety medication by a third. So sometimes the seizure medications will juice up your liver, and that's the old medications, and then you might have to say, well, maybe the reason my Zoloft isn't working, maybe the reason my Paxil isn't working, because of the liver's chewing it up, because of the enzyme induction. Now, the antidepressants, a few of them will inhibit the cytochrome P450, but usually it's a minimal side effect. And again, these are what we call pharmacokinetic interactions, not pharmacodynamic interactions. So they don't actually cause symptoms, but there's variations in the rate at which your seizure medications are metabolized. So, for example, Prozac and Luvox can increase carbamazepine levels and dilantin levels. So, but the interactions are small. But the main one is with the, just in summary, the pharmacodynamic interactions are uncommon. Your enzyme-inducing seizure medications, the phenytoin, the phenobarb, the carbamazepine can chew up your anti-anxiety medication, so you might have to give a slightly smaller, slightly bigger dose, and some medications, particularly Luvox and Prozac, will increase some of the old Tegretol and phenytoin.
Okay. And in those situations, do you typically recommend blood level monitoring if you know?
Yeah, I mean, I think if I was starting, you know, just particularly these certain ones, the fluoxetine, the fluvoxamine, yeah, you might monitor drug levels, yeah. But many times you don't need to.
Okay. And what about the direct impact of psychotropic medications on seizure threshold? Do any of them actually make it more directly make it more likely that you'll have a seizure?
So this is the old chestnut, and there's a lot of misconceptions. Right. And the idea, and I think it's sort of fostered by, you know, the physician's drug reference. You know, whenever you prescribe, whenever you get one of these medications, and you know, you get the leaflets about all the side effects. Right there, it's going to say seizures occur with more frequency. But you know, actually, that's not true. So there's this guy called Alper, and again, he did what's called a meta-analysis. So meta-analysis is a study where they get lots and lots of different papers, and they pull them together and they do a statistical analysis. And what they did was they looked at people that had been prescribed tricyclics, which are the old group of medications, people that were prescribed SSRIs and SNRIs, and then also they looked at people given bupropion or Buspar, which, like we said, works on the norepinephrine and the dopamine. And, you know, so these were studies where people were randomized. They weren't epilepsy studies, but they were maybe people with depression, and they were, you know, whenever you do a study, the idea is you compare active medication, active antidepressant medication with placebo. And so what they found was that the seizure incidence was higher in the study patients. So what does that tell us? That tells us that people with, it's the bi-directional relationship, people with depression and anxiety that needed to be in a study for an antidepressant medication were more likely to develop seizures. But when you compared the group that were given active medication and the group that were given a placebo, there was a 19-fold increase. So the group that were given sugar pill were 19 times more likely to develop seizures. They never had epilepsy before, but they were just in a trial for depression or anxiety. So the idea is, well, maybe these medications actually have seizure protection effects. You know, so that, so I think that turns our old ideas sort of on their head, you know. So I think for all, it's very rare for almost all people, the antidepressant medications, particularly the newer medications, do not lower seizure threshold.
Right, and we know that, you know, there's some of the older medications like Wellbutrin or bupropion can there is good data to suggest that can exacerbate seizures, so that's just not used, right, in people with epilepsy?
Well, bupropion, I think, can be used. The Wellbutrin, I didn't explore that because it's not a medication that I would use. But no, in this study, bupropion did not seem to be, buspar did not seem to be associated with an increased risk of seizures. So I think, I was surprised to read this, but I think sometimes in overdose, and I think anafranil or clomipramine, if you give too much of it, maybe can exacerbate seizures, but if it does happen, it's very, very rare. It's similar to what, I treat a lot of ADD, and we know that 30-40% of kids with epilepsy also have an ADD. And, the Red Book, it says, don't give the stimulant medication because it's going to increase the risk of seizures. But, when I look back, I cannot think of a single child where I think the Adderall or the Ritalin or whatever has actually brought on seizures.
Right. And that, I was going to ask about that later. So, I think that's another common concern that, a stimulant medication that just seems like it would increase the risk of seizures, but there's really no evidence to suggest that. And like you said, from your clinical experience, they can absolutely be stimulant medications for ADHD can safely be used in people with epilepsy. Yeah. So another important thing is obviously sleep is an important behavior for people with epilepsy, and sleep deprivation can trigger seizures. So does that play a role in your selection of antidepressant medication, anti-anxiety medication, in terms of like selecting ones that are less likely to interfere with sleep, or those that may actually help with sleep?
Yeah, I mean, typically medications that, we use, and again, I'm speaking from the pediatric perspective. I try to stick, in pediatrics, we often use, we can try melatonin, and that works for some people. We can try clonidine or Intuniv. These are blood pressure medications which work on alpha-2 adrenergic agents, which can help modulate sleep. I think we try and avoid benzodiazepines, like clonazepam or Ativan. We didn't really talk about that when we were talking how we treat anxiety in people with epilepsy. I think the shift, I think some of the articles recommend Neurontin as the first medication, and then others would be such SSRIs or SNRIs. Benzodiazepines were used for a long time, so that's medication like clonazepam, alprazolam, or Xanax, or lorazepam, or Ativan, but we sort of steered clear of those, and I don't think it would be common practice to, as a first off, to initiate a benzodiazepine just because of issues of tolerance. It works for a while, and then you get used to it. Cognitive effects, it makes you tired and sleepy, and obviously issues of dependence. Now, whether or not some medications are more helpful in, Remeron, that can be helpful as a sleep agent. But I think it's an important consideration. We know that there's an important interplay between sleep and seizures. Is it worth getting a sleep study, making sure you don't have restless legs or something like that? Is there obstructive sleep apnea? I think it's always important to look at that. Because we know that there's this relationship between obstructive sleep apnea and sleep, and if you have obstructive sleep apnea, it fragments sleep, you're always tired, and that can bring on seizure.
Right. So there's several common epilepsy-related side effects or symptoms that you would want to avoid exacerbating through a psychiatric medication, things like drowsiness or fatigue or slowed thinking or problems with memory or attention. Do any of the commonly used psychotropic medications affect, or would they exacerbate any of those common symptoms or side effects, or do they tend to be different in nature?
Difficult question.
Sorry.
But you know what? I did. I was reading it this morning. I did. So let me try and. Oh, I lost it. There are certain medications which are not as. So again, a lot of times it's individual, and a lot of times when we're trying an SSRI, I think the important thing, what I tell people is these medications take time to take effect, right? It takes 4 to 6 weeks, so don't give up on it too soon. 5%, 10% of the time, you're gonna call me back and you're gonna say, Doc, I don't know what you're doing, but I hate this medication. It makes me tired, it makes me sleepy, so I say, all right, well, let's try something else, So I think there's an individual component,
right.
But from what I remember, what I was reading is that, the SNRIs are often less well tolerated than the SSRIs. That's the Cymbalta, which is the duloxetine. They're more like, you can be, they can cause hypertension. They can make you feel edgy and shaky. So the ones which in this meta-analysis, and I can't find the exact case, I'm sorry, but I think it was the fluvoxamine, which is Luvox, and it would surprise me a little because that was one of the first medications to be approved in childhood for obsessive compulsive disorder. Fluoxetine, I think, fluvoxetine, and then the venlafaxine, which is the effects. They were ones which were probably not as well tolerated. And then, of course, the tricyclics, things like clomipramine or enapronil. And, we didn't really try and dissect out the different types of anxiety. We know that, we talked about periactual anxiety, but, anxiety in people, sometimes it can be a post-traumatic stress disorder. So 50% of people with epilepsy also have post-traumatic stress. We know that social anxiety disorder is more common in people with epilepsy. In children, phobias and obsessive compulsive disorder can be more common. There's ideas about differential effects of different medications. So, for example, obsessive compulsive disorder often is hard to control. It's one of the indications for CBT, so that's obsessive compulsive disorder. And the two conditions which may benefit most from therapy are not so much your generalized anxiety, not so much your social anxiety, but obsessive compulsive disorder and I just said it.
Post-traumatic stress disorder.
Post-traumatic stress. The evidence is a little. You have people that say yes, people that say no. Panic attacks.
Yeah.
And it's compulsive.
Okay.
So I think you need to think about the background. I mean, because there are, like we said, we worry about potentiation of weight gain, so you might avoid Neurontin or gabapentin, potentiation of sexual adverse effects, osteopenia, bone health is an important consideration. Particularly with the SNRIs, you have to monitor sodium levels because you can have a drop in sodium levels.
Right. All right. Well, I had some more questions, but just given the time, I want to make sure we have some time for questions from the audience, so from our participants. So I'll go ahead and unmute the lines, and then I just remind people, if you don't have a question you'll be asking, please do keep your line muted. And if you are asking a question, just go ahead and jump right in, and we'll do our best to answer. So just a moment here. Okay, who'd like to get us started with a question?
So I'm sorry, I was trying to take notes and keep track. And earlier in the call, when we were talking about mental health issues being common with epilepsy, along with the mood disorders, depression, and anxiety, you had made a comment about surgery, and I didn't get what you were saying, that something about the surgery options were not always favorable. Was that because of the mental health disorders?
Yeah, so good question. So, what they found is that if you have epilepsy and anxiety or depression, you are less likely to do well after epilepsy surgery. So this is what we call, the ideal, when we do surgery, we want you to be seizure-free, right? So being seizure-free is what we call an Engel Class 1 outcome. But what they found is that people that, and there's 3 studies that looked at this, they didn't separate depression from anxiety, but anxiety was was more common than depression. But what they found is that if you had depression or anxiety, you were less likely, you were twice as likely to not be seizure-free after epilepsy surgery. Now, that's not because you're worrying too much, or it's just because we know that the epilepsy pathway and the anxiety pathway in the brain involve the amygdala. And I guess the idea is that if you have more extensive involvement of the limbic circuit of your amygdala and all its connections, then that might be why, if you have anxiety and depression, you will not do as well after surgery.
Okay, thank you for that. So how do we increase the amygdala?
Oh, I wish we knew. I don't think anyone's done any studies on that. Whether the amygdala is plastic. I think you could maybe preventing seizures. There's this whole idea that sometimes the more seizures you have, seizures beget seizures. It's called kindling. Very controversial. Not everyone agrees that it happens, but whether or not doing your best to keep your seizures under control. I don't know whether anybody has done, I'm sure there are studies which maybe look at mindfulness techniques and medication techniques and whether that helps with the amygdala. It makes sense. So, maybe some...
Yeah. I know there have been studies talking about aerobic exercise promoting hippocampal neurogenesis. So now, does that, what we don't know enough about that yet to say whether that has any clinical significance, but certainly, at least in theory, kind of lends or supports the idea that there can be some regeneration of neurons in as a result of exercise. So
right.
Yes, it's a whole mind-body connection, right? So I think, like Russ says, is there are studies which show that exercise is helpful in depression. So it's not just the meditation and the mindfulness, but also a healthy mind and a healthy body.
Thank you, Doctor. I just had one last thing that I wanted to touch on, if I may.
Sure.
When you were talking about the comorbidities and things like that that go along with epilepsy, like you were saying, the ADD, OCD, PTSD. So I'm a caregiver for my almost 18-year-old daughter who has refractory epilepsy, and I am in therapy for myself because of my own anxiety and, the things that go along with being her caregiver. And in talking with my therapist, she's not referring to it as PTSD. She's calling it chronic traumatic stress because it recurs on a daily basis. Have you heard that?
So, Russ, can you repeat that, or the essence of it? The line was a bit garbled.
Oh, sorry. Yeah, she was saying that in talking with her therapist, the therapist mentioned the distinction between post-traumatic stress disorder and what she calls chronic traumatic stress disorder. So I haven't heard of that, but have you heard of that distinction?
Yeah, I mean, when I hear Dr. Barkley talk about post-traumatic stress, I think, Doctor, and I think I agree with him. I think it's a mistake to call it a disorder. It's, what is the definition of post-traumatic stress is you have a stress, a big trauma, and it's normal to have symptoms of anxiety and depression and nightmares and waking up in the middle of the night. So it's not a disorder. It's a completely normal response to, your amygdala, which ties in emotion and fear and memory all together. So maybe a better term is post-traumatic stress injury. So it's something that any of us that have a big stress in our lives, we're going to be left with an injury. Now, the definition of disorder is if those symptoms continue, the flashbacks, the nightmares, the avoidance, more than 6 months. So I don't know if that's what your therapist was talking about, was that maybe they lingered, the symptoms have lasted a long time. But, again, I just want to voice that maybe PTSD is not our best choice of terminology, because I think for people with epilepsy, it's like the depression mice, the swimming mice that are dumped in a pool. This is a normal response to a major stressor.
Russ, this is Renee. May I speak to that for just a moment?
Yeah. Sure.
Yeah, hey everybody. This is Renee Rodemer, the support specialist at the Epilepsy Foundation of Michigan, and thank you, Dr. Constantinou, for that. I just also wanted to add that, and this may be what you were talking about, is that, there's a diagnosis of PTSD, but there's also researchers and many psychologists for a long time have been wanting to make a diagnostic criteria for what CPTSD, which stands for complex, and that has to do with chronic connection or long-term post-traumatic stress. So I wonder if that might be what your therapist was talking about.
Thank you, Renee. I appreciate it.
Yeah. Mm-hmm, sure.
And I really appreciate being invited to this today. Thank you, Doctor and Russ, for doing this. I have learned so much.
Oh, great. Great. Well, we've got a few minutes left. Other questions that anyone has? And can I just remind people to please mute your lines if you have background noise? I'm hearing quite a bit of background noise.
I have a question.
Go ahead.
Can you hear me? I might have background noise too because I have my son here. But
okay.
I'm wondering if you could speak to how to ensure a psychiatrist is familiar with anti-epileptics sufficiently. I guess that's been my biggest concern. I've thought of recommending psychiatric care for a loved one because a couple meds is somewhat effective, but I just don't know if I feel super convinced that the psychiatrists are going to be well versed in epilepsy. Nor was I really convinced that the neurologist was super adept in the psychiatric world. So I just wonder if there's steps being taken to enhance that, or if there's a way to ascertain whether someone's real familiar with that.
Yes.
Does that make sense? Like, is there any credentialing or something that says, hey, I know this area better than maybe another doctor?
Okay. So, yes, that's a very good question. And, I think, sometimes with complex issues, you need a team, right? And I think for someone with epilepsy and complex depression, maybe complex post-traumatic stress, you need, because a neurologist has his own particular set of tools. So we know a little bit, hopefully we know a lot about seizures, a lot about seizure medications. Maybe we know a little bit about anxiety and depression, but not as much as the psychiatrist. Now, the psychiatrist, he's going to know more about anxiety and depression, not so much about epilepsy. So both, a neurologist is boarded in both psychiatry and neurology, and a psychiatrist is boarded in both, but you have your special subspecialty. So, again, it's teamwork, and I think, the best idea is, the epilepsy specialist looks after the epilepsy medication, and if you need a psychiatrist, the psychiatrist looks after the psychiatry medications, and then you can talk to each other. They can talk to each other if it's necessary. You see? I don't know if that.
Yeah, it sounds like that. Oh, sorry. It sounds like that certainly supports the idea of. Sorry, a lot of background noise there. Sorry. It sounds like that supports the idea of potentially having your psychiatrist and neurologist within the same health system so that they can more easily access the medical records, through whether it be electronic medical record. They can access that information and know exactly what medications the patient is on for both epilepsy and for anxiety or depression.
Yeah.
That's a great suggestion. Thank you so much to both of you.
Sure. Dave, did you have a question or a comment?
I kind of concur exactly with the last point. I do subscribe to counseling, and the therapist, the psychiatrist, interacting or being familiar with epilepsy, surgeries, medications, all the different interactions and problems. And what it sounds like Henry Ford does is you do have more of a comprehensive epilepsy program where that is tied together. So I think that's excellent. I just want to make that comment.
Yeah, I think like you said, teamwork is always important, and
excellent.
I work very closely with Andrea, that I'm sure many of you know, as a counselor, and we're always talking to each other about best ways to manage all the different issues. So in any busy system, it's hard to get that collaboration, but I think that's you need a team and you need a village, So I think if you can search for that and look for that, that's always good.
Without a doubt. Thank you.
Okay. Well, given the time, I think we'll go ahead and wrap it up, and I appreciate everyone participating today, and thank you so much, Dr. Constantinou, for a really in-depth conversation about this complex topic. So if people do have any further questions, please feel free to reach out to us at 1-800-377-6226 or visit our website at epilepsymichigan.org or the national office's website at epilepsy.com. So thank you again, Dr. Constantinou, and thank you, everyone, for participating.
Bye, Dr. Constantinou.
Thank you.
Thank you,
everybody.
This is great.
Thanks.
Have a good afternoon.
Thanks so much.